Hello everyone, welcome back. I hope everyone's doing wonderful. Today's lecture will be on approach to hyperkalemia. Hyperkalemia is a life-threatening condition making prompt evaluation and treatment necessary. Quick treatment on clinical suspicion is also indicated. Normal range of potassium is between 3.5 to 5.5 milliequivalents per liter. We try to keep the level at around 4 milliequivalents per liter for every patient. Now let's talk about pseudohyperkalemia, seen with hemolysis, thrombocytosis, leukocytosis. If the plasma is pink, then it indicates that there might be some sort of hemolysis that is ongoing, and that is giving us the hyperkalemia. We can use two samples with heparin and clot file. If the clot file has more potassium, then it indicates pseudohyperkalemia. We should use large veins and gentle traction while drawing blood without using a tourniquet to reduce the chance of hemolysis. Now let's talk about some etiologies. Hyperkalemia can be due to high potassium intake or reduced excretion, or it can also be due to increased transcellular shift. Some examples of food that contains high level of potassium are bananas, citrus juice, tomatoes, lima beans, spinach, and raisins. Processed foods can also contain high level of potassium. Reduced excretion of potassium can be due to some conditions like acute kidney injury, chronic kidney disease, cardiovascular diseases, mineralocorticoid deficiency, Addison's disease, and mineralocorticoid resistance that we commonly see in RTA type 4 in the background of type 2 diabetes mellitus. Some drugs that can cause hyperkalemia are ACE inhibitors, ARBs, digoxin overdose, direct renin inhibitors like aliskiren, calcineurin inhibitors like tacrolimus cyclosporin, heparin, low molecular weight heparin, dabigatran, antifungals like ketoconazole, MRAs, non-steroidal MRA like finerenone, INAC blockers, amiloride, triamterene, trimethoprim, and pentamidine. Both are used for pneumocystis pneumonia prophylaxis or treatment. Also can cause hyperkalemia. Increased transcellular shift can be caused by rhabdomyolysis, tumor lysis syndrome, trauma, diabetes mellitus, and rare autosomal dominant disorder, hyperkalemic periodic paralysis can also cause hyperkalemia. Now let's come to the clinical manifestations of hyperkalemia. So hyperkalemia can typically involve the heart and the skeletal muscles. The typical ECG changes that we see with hyperkalemia are tall peaked T waves when the potassium level is around 5.5 to 6.5. When the potassium level goes to 6.5 to 8.5, it can give rise to tall peak T waves, prolonged PR interval, decreased amplitude of P wave, widened QRS complex. When the potassium level goes above 8 milliequivalents per liter, we can also expect absent P waves, interventricular block, wide QRS complexes, sine wave pattern, ventricular fibrillation, and cardiac arrest. If we remember, in the SLS protocol, the 5H, 5T for pulseless electrical activity, it also includes the hyperkalemia. So if there is hyperkalemia, we need to treat it. Musculoskeletal manifestations are typically seen in severe hyperkalemia, skeletal muscle weakness, paralysis, respiratory arrest, recurring intubation, and mechanical ventilation. Now, let's come to the treatment and let's discuss a clinical scenario so that we can get a better idea of how to manage a patient with hyperkalemia. So the case is a 70-year-old female presenting with shortness of breath and dizziness. Blood pressure on presentation is 90/60. Heart rate is 20, irregular. Saturation is 95. GCS is 15. Blood glucose level is 212. Now let's manage this patient. Emergency ECG is showing us bradycardia. We don't see any obvious P waves, and wide QRS and tall peaked T waves. So initial step, we'll start with airway, breathing, and circulation. As the saturation is maintained and patient has no airway compromise, we will not intubate the patient. But due to severe symptomatic bradycardia, we tried IV atropine, but that failed. So we immediately shifted the patient for transvenous pacemaker placement. Urgent venous blood gas also revealed potassium of 9 milliequivalents per liter. So we started intraprocedure calcium gluconate, followed by 10 unit regular insulin with 25 dextrose infusion. This will be our segue to talk about calcium in hyperkalemia. It only stabilizes the cardiac membrane. It does not reduce the potassium level. Now let's talk about the available formulations of calcium. So we have calcium chloride, better in patients having cardiac arrest because it has higher elemental calcium level, approximately 3 times of that of calcium gluconate. Higher risk of extravasation is always there, and the usual dose is 10% calcium chloride, 10 ml over 5 minutes. Calcium gluconate better in patients who are not having a cardiac arrest. It has less elemental calcium, approximately 1/3 of calcium chloride. It has less risk of extravasation. Dose is 10% calcium gluconate, 30 ml over 10 minutes, or we can also use 10% calcium gluconate, 10 ml over 1 minute, and we can also repeat that every 3 to 5 minutes. Effect is almost immediate. Now the second step in managing a patient with hyperkalemia is shifting the potassium inside the cell or getting rid of the potassium from the body. We can use insulin dextrose, beta-2 agonist, sodium bicarbonate to shift the potassium inside the cell. And we should also check potassium level at a regular interval depending on the severity of hyperkalemia or the symptoms. Now let's talk about the insulin dextrose. We typically use 10 unit insulin with 25 or 50D infusion. We follow that with 5% dextrose at 100 ml per hour for 5 hours if glucose level is less than 126 milligram per DL. We can also avoid the 25 or 50D infusion along with insulin if blood sugar level is more than 300, because hyperglycemia can worsen the hyperkalemia. Before administration, we should always check the point of care blood glucose level. Now let's talk about the beta-2 agonists. We typically administer beta-2 agonist in the form of nebulization. We can use albuterol or salbutamol. Both of them are same things but different names. The concentration should be 5 milligram per ml to reduce the volume. Dose is typically 10 to 20 milligram over 10 minutes. It has additive effect over the insulin. I have shown it should not be used the respules, but we can use the respirator solution, which has 5 milligram per ml concentration. So approximately 4 ml of the solution should be used. Now let's talk about the sodium bicarbonate. It is not much useful. Only use if serum bicarbonate level is less than 10 milliequivalent per liter or if the patient is in severe metabolic acidosis. Not to be used in cardiac arrest patients, can suppress the cardiac activity. Used in patients with CKD and serum bicarbonate level less than 22 milliequivalent per liter, but this indication is not for hyperkalemia. After giving the initial treatment and management of hyperkalemia, ECG still shows tall peak T waves, junctional rhythm at 50 beats per minute, and the QRS is still wide. Repeat potassium level after 1 hour was 9.5. So what to do next? So we started hemodialysis for the patient, and once the potassium level was reduced, the patient returned to normal sinus rhythm, and a final diagnosis of symptomatic hyperkalemia in chronic kidney disease was made. So for chronic management or further management, we can use potassium binding resins, sodium polystyrene sulfate, or commonly known as K-bind. It is typically used for short-term use. Rectal route can also be used. There are some incidents of colon necrosis when it is combined with sorbitol. It is a black box warning for K-bind. Patyromar, which is not currently available in my setup. Typical dose is 4.2 to 12.6 grams twice per day. It has excellent safety profile, but there are some concerns that it might bind to some other drugs. And then there is zirconium cyclosilicate. The dose is typically 5 milligrams once daily. Useful in heart failure and CKD stage 3B to 5 patients. Patyromar and zirconium cyclosilicate are typically useful in patients with CKD who are on ACE inhibitors or ARBs to reduce the progression of their CKD. For long-term management, we can advise potassium-restricted diet, and we can also consider reducing or avoiding the medications. There are some dilemmas with ACI and ARBs in patients with CKD because it can reduce the progression of their CKD, but it can also cause hyperkalemia. So if someone is developing hyperkalemia who are getting ACEIs or ARBs in the background of their CKD, we can try reducing the dose, but we can also try adding patyromar or zirconium cyclosilicate. If that does not work, we have to stop the drug altogether. We should also avoid fasting in dialysis patients because fasting can reduce their body insulin level, and that can give rise to a high level of potassium. But as they are dependent on dialysis, they are not able to get rid of the potassium on their own through their kidneys. So if someone who is planned for a surgery and we are keeping them NPM or planned for something, some other imaging, we should be putting them on IV 10D at 50 ml per hour. We can also add 10 units insulin if they are diabetic. In some select patient population, we can also use loop diuretics that can also get rid of some potassium from the blood. We should also address if there is any constipation. We should use laxatives to address that. If there is adrenal insufficiency, we can supplement glucocorticoids or mineralocorticoids like fludrocortisone. In cases of hyperkalemic periodic paralysis, which is a rare autosomal dominant disorder, we can try nebulized albuterol prior to any workout. And with this, I conclude my lecture on hyperkalemia, and thank you for listening. If you have any questions, feel free to reach out, and as always, thank you.